Kia ora and welcome. I'm Adele Gauthier from Breast Cancer Foundation NZ, and tonight we're talking about breast cancer in older women. What difference does your age make to your treatment, if any? And how does a breast cancer diagnosis connect to the other things that are going on in your life as you age? Well, that's what we're here to find out, and tonight we have three panelists who will share their knowledge and experience with us. Let me introduce you. With me here is patient Frankie Robson, breast surgeon, Mr. Adam Stewart, and medical oncologist, Dr. Edmund Ang. We'll also have some input from radiation oncologist, Dr. Jayaram Mahanamurali, who can't be with us tonight. Okay, let's get started. First, Frankie Robson. Frankie was diagnosed with breast cancer a few years ago at age 76. Frankie, thank you so much for being here tonight. Tell us a bit about your story and the treatments that you had.
My story began on the 15th of December, 2019. I came home from work, had a cup of tea and a little biscuit, and then I brushed the crumbs off my breast. And I thought, oh, what's that? Didn't really think too much about it and continued on. So I kind of slept on it over the Saturday and the Sunday night. And then I thought, I think I should speak to my doctor. So I rang up my doctor on the Monday, had an appointment on the Tuesday. By Friday, I had an amazing appointment to have a mammogram, ultrasound, and biopsy, which was quite different, quite different. Unfortunately, I had to wait until the new year to have a definitive result. So I spent the holidays waiting for the phone to ring. It played on my mind a lot because I wasn't familiar with what breast cancer looked like. I was finally had an appointment with the amazing doctor, Mr. Harmon, Richard Harmon, and he told me I had breast cancer. And he said, I'm booking your surgery for the 30th of January. So I had a partial mastectomy, 3 lymph nodes removed. The surgeon was absolutely lovely. Had this amazing friend take me to and from appointments. Her name was Elizabeth Lavery. So unfortunately, COVID came, so she wasn't able to complete the journey with me. So on Easter in 2020, I had 3 weeks of radiation on my own. Taxi rides to hospital, perfect, beautiful, all done across the bridge and back, 45 minutes, unheard of. The first time was a bit scary and claustrophobic, but the team were so caring, so funny. And on my last day, it was a big celebration, you know, with chocolates and cookies and hugs all around. It was really, really, at the end of the day, was a wonderful experience. So I was prescribed by the oncology department to have letrozole, which is a hormone. It wasn't that good for me. It seemed to cause me acute joint pain because I already had osteoarthritis, but I persevered with it for 2 years. And then I went back to the oncologist and said, is there anything else we can do? And she said, well, we can swap to another drug called tamoxifen. I stuck with it for 2 years, but it made me kind of anxious and angry. And my poor little dog, he seemed to get the brunt of it, you know. So I went back and we had some more blood tests done and tests. And then we decided, yes, we'll see how you go by coming off the drugs at all. So far, I feel really, really good, really good. On 2022, I had an aggressive face cancer. And then July 23, I had a knee replacement, which was great. Now it's the end of October and I'm off to UK next month and I'm feeling absolutely superb. I work 20 to 30 hours at my local rugby club, 4 to 5 hours caregiving, and I have a big birthday at the end of the month. My biggest advice to anybody is check, and double check, and just see your GP if there's anything at all, no matter what it feels like, looks like, see your GP.
Fantastic. Thank you so much, Frankie. You're an absolute dynamo.
Thank you.
Now we're going to hear from breast surgeon Mr. Adam Stewart, who works in both public and private practice in Waikato. Oops, sorry, send that to you, Adam. Adam, thank you for trekking north to join us. You've treated women of all ages with breast cancer. Is there anything different about older women? Perhaps you could tell us what you think.
Well, thanks, Adele, and thanks to my fellow panelists, Frankie and Edmund. It's my very great pleasure to talk about a subject that I'm very passionate about, breast cancer in older women. So we know that breast cancer is becoming more common in Aotearoa, New Zealand. And as of 2023, breast cancer is the #1 cancer for women in this country. It used to be the case that about 3,000 women were diagnosed annually. That's now increased to over 4,000 cases. There are a small number of men who are diagnosed with breast cancer. And sadly, 700 women succumb and die from breast cancer every year. We also know that Maori and Pacific women are at greater risk of dying of breast cancer. But ostensibly, the main risk factors for breast cancer are the simple fact of being a woman and getting older. Those are by far the most common things. A lot of the other things that you'll read and hear about is much less common, but they do include such things as being overweight, smoking, but also importantly, a family history of breast cancer. So what age do women get breast cancer in New Zealand? Whilst it's true that the majority of breast cancers are found in the eligible free screening age in New Zealand of 45 to 69, you can see on this graph from the New Zealand Breast Cancer Foundation's publication, 30,000 Voices. Have a look at all the women who are diagnosed over the age of 70. That's more than 1/5, or over 20% of women are diagnosed with breast cancer over the age of 70, which is highlighted there in that bottom box. And that's a significant amount of breast cancer being diagnosed in older women. We also know that women are living longer in this country. In the 1950s, it was expected for a woman to live till about 72 or so. Now, at birth, a woman is expected to live to about 84. But the interesting thing about life expectancy is that it's different. It changes as you age. So if we look at the upper limit of the screening age, currently 69 in New Zealand for free eligible screening through Breastscreen Aotearoa. I looked at this about 8 years ago, and a woman who had attained the age of 69 had at least 17 years of life ahead of her, so she would be expected to live until 86. Now it's actually increased beyond that, and so a woman who's age 69 is expected to live another 2 decades. So what that means is that by the time that you've reached the age of 69, you've already outlived many of the other diseases and other risks to your life. This in itself, I believe, is a compelling argument to extend free screening beyond the age of 69. And that's one of the things that we're looking at in New Zealand, in line with other similar jurisdictions in other countries. But this is for well women. This is women who are absent of many of the medical comorbidities and other illnesses. We also know that there is a scientific benefit for treating older women, and there's a study published by my good friend and colleague, Mr. Alexander Ung in Auckland, which demonstrated longer survival for women with screen-detected cancers or cancers that's found at an early age through screening. Many women in the older age bracket are fit, are healthy, are active. Some women are working, including my friend Frankie, at age 70,
Something like that.
70, we'll just say in her 70s, still working, and they are active, contributing members to our society. So I would push the point that older women, therefore, are entitled to breast cancer treatment, just like others. And so this really comes down to an attitudinal change in many different groups within the community, including the health sector. I feel that potentially in the past, historically, there has been age discrimination. There has also been unconscious bias, including even amongst health professionals. You'd agree with that?
Absolutely.
Dr. Edmund? Yes. But I think that the tide is now shifting in favour of treating older women with breast cancer, but also attitudes of women themselves have changed. They are pushing for active treatments. There is a difference between age and frailty. So there's the chronologic age, and then there's how frail a woman is according to her illnesses. And just briefly talking about this scale that you can see on your screen, which is called ECOG performance, which ranges from grade 0, which is a fully active woman, all the way up to grade 4, which is a woman who is completely disabled and is not able to do any self-cares. And often it's the health professionals that will be able to grade a woman's treatment according to these performance statuses upon consultation. It's important to know that when an older woman is diagnosed with breast cancer, the first person whom she'll meet will normally be a breast surgeon or a surgical oncologist. And for many women, that could potentially be a frightening experience. But I'm here to assure or reassure older women that in many cases, it's actually not that bad. And my friend Frankie here has said that in her case, it actually wasn't that bad, and her breast cancer was successfully treated, and we're all very glad that she's alive and well today.
Me too.
And particularly if in the case of women who have screened, older women who have screen detected cancers, that is without presenting with a symptom, the outcomes are even better. I would like to stress the point that surgery of the woman's breast is surface surgery. The breast is a superficial organ. We also operate on the armpits or the axilla. It's not deep cavity surgery. It's not like having a heart bypass. It's not like having a total hip replacement or deep pelvic surgery. And recovery is usually within days, or in the case of a mastectomy or removal of the whole breast, a few weeks. In Frankie's case, she was in one night in hospital and recovered from her breast surgery within a few days. And that's excellent. There is a difference in the type of surgery that we do in women, older women notwithstanding, and that includes breast conserving surgery, where a small piece of breast is removed, usually followed by radiotherapy. And Dr. Edmund will talk about that in more detail. First, it's mastectomy, which is removal of the whole breast. Here are some basic photos of the different types of breast surgery. On the left of your screen, you'll see a scar from breast conservation. And on the right, you'll see what it looks like to have a mastectomy or be flat-chested. I would say that we can even improve on this further, particularly with breast conserving surgery, and trying to hide the scar in a cosmetically acceptable position so it's barely noticeable. In terms of invasive cancers, we often do some small operating on the armpit or the axilla, and that's called a sentinel lymph node biopsy. If the cancer has spread to many lymph nodes, we'll often offer an axillary dissection to remove all the cancer in the armpit. If it's invasive cancer, you will normally need to have some form of surgery to the armpit or the axilla. If it's non-invasive, or what we call DCIS, usually not any armpit surgery or axillary surgery is even required. So the surgical options are actually, for older women, very similar to younger women, with the one exception that full breast reconstruction is uncommon for women over the age of about 80, although it is not uncommon for women in their 70s to request a full breast reconstruction. I've got some patient photos, and by the way, this patient has consented to the use of these photos. This is one of my patients who had, on the left of your screen, a small breast cancer at the lower part of the left breast, and that was removed at surgery. And then I've shielded the blood and gore to make it more palatable for this audience. But just look at the photograph on the right-hand side. I've covered the nipple there for dignity, but that pink line there is the length of the scar in the inframammary crease of the breast, or where the bra wire would normally sit. And so that scar is not even noticeable to that woman or anyone else. I'd also like to show you a newer technique which has come into New Zealand within the last 12 months, where extremely small breast cancers can be removed. And this is a short video of a tumour only weighed 7 grams. So in that case, before the operation, a radar reflector was placed within the breast cancer, and it was a very small operation, and the scar that woman needed to have was only 1.5 centimeters. So a very cosmetic, appealing result for that woman. There are alternative breast conservation localization techniques, including hook wires and magnetic seeds as well. And we'll just go forward again. In terms of follow-up for breast cancer for older women, it's really easy, actually, in most cases, and that requires a clinical follow-up of about 5 years. Normally, the patient will be seen once or twice a year after all treatments are complete. Mammograms, which are breast x-rays, every year, and that's really about it. We try and get women back on their feet, enjoying life as much as possible. As in Frankie's case, she was back to work within a couple of days, something like that.
A few days, a week maybe.
A week. And that's what we would expect for the majority of women with suitable for breast cancer operations. And that's just excellent. I'm really happy to hear that, Frankie. Thank you.
Thank you.
So in summary, older women are important to our community. They deserve breast cancer treatments. Breast screening saves lives and reduces the suffering in all women, but especially in older women, because it can actually facilitate smaller operations and less morbid surgery and treatments, and less chance of chemotherapy, which we might hear about in a little while. And the surgical options are actually very similar to younger women. So with that, I'll conclude, and thank you very much.
Great, thank you, Adam. That was super helpful. Now we're going to hear from Dr. Edmund Ang, who's a medical oncologist at Whangarei Hospital with a special interest in treating older patients. Edmund, we really appreciate you joining us tonight. Thank you in advance for sharing also some thoughts from radiation oncologist Dr. Jayaram Mohanamurali. What are the considerations that you and your colleagues take into account when you're treating older women?
Oh, good evening, everyone. Such a pleasure for me to be here today. I just want to say, Frankie, I'm humbled by your story, and I'm also inspired by your passion, Adam, in surgery. So that's wonderful. And Adele, as I said to you, it's such a treat to be here today, because you're allowing me to speak about a topic that I'm really passionate about, and actually 2 topics that I'm passionate about, and that is breast cancer and cancer care in the elderly. So thank you once again. I am an oncologist, and so I will be presenting the perspective of a doctor that offers chemotherapy, hormone therapy, as well as targeted therapy. But as Adele pointed out, I have got a couple of slides that I will share from Dr. Murali. So just repeating a couple of things that Adam has already said in his presentation, that age is the most important risk factor for the development of cancer. And with people living longer, there's more cancer being diagnosed. And therefore, we need to get good at looking after older people with cancer. And particularly in this webinar, breast cancer. Now, we know that almost close to half of patients with breast cancer are 65 years old or older. And so the question that we need to answer today is, should older women and men be treated with breast cancer, be treated differently to their younger counterparts? But who or what actually defines a person who is old or elderly? Now, in medicine, we often use the age 65 or 70 as a sort of a magical cutoff point to say that this is someone who is old or elderly, but there are many pitfalls to this definition, as we will see as we go along this presentation. I'm dividing my presentation into two parts. The first part, I will be talking to you about some of the key challenges that we face when we are treating older people with breast cancer. And then I will go into some caveats, some special considerations, which are more specific. So first, I'm going to tell you the challenges. Now, broadly speaking, there are three important challenges. And the first is the lack of evidence. Patients over 70 make up 42% of the breast cancer population, but only 24% of clinical trial participants. Now, clinical trials are the ways in which doctors determine what is the best treatment for a certain type of cancer or a certain type of breast cancer. And so we're seeing consistently from historical records and until today, underrepresentation of older people in these crucial trials. In another study, 34% of women over 65 with stage 2 breast cancer was offered clinical trials, versus 68% of their counterparts who are under 65. And the greatest barrier is actually the doctor's perception about age and side effects in a study. The other thing to consider is elderly clinical trial participants are often exceptionally fit, the ultra fit, and so they may not necessarily represent their population. So what happens is we have to extrapolate the results of studies where older people are underrepresented into the care of elderly patients. And this may not actually be the right thing to do. Older patients might not get as much benefit from a certain treatment that a younger patient might obtain. So how do we overcome this challenge? Well, we need to increase clinical trial participation in older patients. But for you in this webinar, listening to this talk, you can self-advocate for clinical trial participation. If you are a patient or you've got a family member or a friend who's a patient and you're seeing the oncologist or the doctor, ask, is there a clinical trial that I can participate in? If you get a negative answer, say no. Don't stop asking, because there are different clinical trials for different phases in a person's journey through cancer. The second challenge has already been touched on by Adam, and is perhaps the biggest challenge that we have when it comes to managing breast cancer in older patients, and this is inadequate assessment. Now, we all have seen 80-year-old friends or family members who look like they are in their 60s and are still doing marathons. And then we've got the 60-year-olds that are struggling to live an extra day. And this is because aging is a process where a person loses reserves, heart reserves, kidney reserves, lung reserves. And that loss of reserves results in a drop in a person's ability to compensate when there is an insult. And the insult could be an infection, or it could be the chemotherapy a doctor gives to a patient, or a hormone therapy a doctor gives. And different people decline at different rates. And as Adam has pointed out, there is such a thing as chronological age, which is how old a person is by year, or the physiological or the biological age. And we know that the physiological age is what actually determines the appropriate treatment plan for a patient. And unfortunately, like many things in life, there's no single test that can tell us your physiological age is this. The way to get as close as possible to the physiological age is to do a thorough assessment. And this thorough assessment takes time and takes effort. And unfortunately, we're not quite there yet here in New Zealand. At the moment, if you were to see your doctor with a diagnosis of breast cancer and to talk about hormone therapy or chemotherapy, you'll likely be there for 20 minutes and an hour, where the doctor has to address other issues, such as your other health problems and also the diagnosis. So there's little time to go into details that are actually quite important in the decision-making as to what treatment is best for a person. And Adam has talked about the ECOG performance status score, which is a tool that we do use regularly in the clinic, but this tool was largely validated in younger people and may give us some answers in older patients, but not adequate. And then there's the eyeball test, which is what doctors say a person looks as he or she walks into the clinic. Now, these are inadequate ways of assessment. So why do we want to assess a patient properly? Well, because we want to identify this entity called frailty. And the best way to describe frailty is using this picture. So a fit patient or a fit person is a person where you can pull a few blocks away and the structure is still standing. But a frail person is someone who is vulnerable, that removing 1 or 2 blocks can cause the entire tower to tumble. This is another reflection of what frailty is. On that graph that you can see, on the x-axis, or on the left side, it's the functional ability of a person. Above that dotted line is a person who is independent. Below is a person that's dependent. The green line represents the person who's not frail. So if you give a person chemotherapy, or the person has a urine infection, they might get a dip in their functional abilities. But you can see that the dip is shallow and they recover quite quickly to the baseline. Whereas a person who is vulnerable or frail, the insult leads to a deeper loss of function, moving from independence to dependence, a real slow recovery to independence, and then they may not ever return to the level of independence. So older patients can get the same degree of benefit from cancer treatment. They may have the same rates of side effects, but side effects tend to be more severe because of the reduced reserves. And side effects can affect independence, and a person may not recover to previous levels of function. And so we need to do much better with assessment. And there was a movement that started in France called geriatric assessment, where you're trying to look at a person holistically and assess a person holistically so that you can make the best recommendations for treatment. And so in New Zealand, we are about to start a special interest group focused on doing this better and advancing patient care who have cancer at an advanced age. So I'm going to give you an example. If we had an 80-year-old patient who has been diagnosed with estrogen-positive, hormone-positive early breast cancer, and has had the most important treatment, which is surgery with Adam, she comes to me and she is here to talk about whether I should give her chemotherapy or some form of hormone therapy. Now, what I want to know is what is the person's estimated life expectancy without cancer? And with cancer, how much lower is it? If we offer treatment, how much improvement can we do to the life expectancy? And does the treatment lead to side effects that can worsen the life expectancy? And balancing the pros and cons of treatment, we can decide if treatment should be done or shouldn't be done. Now, for this 80-year-old with hormone-positive breast cancer, I would like to try some hormone therapy. I want to know what medications the person is on to see whether there's interactions. And as Frankie has pointed out, mobility, falls, and arthritis is a major consideration. So if a patient has a risk of falling, have a problem with balance, is already suffering from arthritis, then I do not want to give this person an aromatase inhibitor, one of the hormone therapy drugs, because that can lead to reduction in the strength of the bone and fractures. It can lead to more muscle aches and pains, worsening arthritis. Some of my patients tell me that they feel 10, 20 years older when they start one of these medications. So I want to be sure, or I want to at least know that is a concern. I want to know the mental health of the person, because some of these medications can cause a person to fall into depression. And sometimes the benefit of the treatment is much less than the risk of depression. I want to know if the patient has any memory issues, because that's important to ensure that the person is able to undergo the treatment safely and is able to be compliant to treatment, and so on and so forth. I want to know the nutritional status, the social support, the function of the person in the community. And all of this has to feed into a multidisciplinary team. So this is a team of doctors, nurses, and allied health professionals that help to assess if a person is well enough to have treatment, try to plug 1 or 2 issues that could be the barrier for a successful treatment, and also help to assist the person through their course of treatment. And so when we do a good assessment, we also need to have a team behind it to optimize a person's ability to go through treatment. Lastly, something that Adam has also touched, and that is basically the perception of the doctor, the patient, and the family. Some people write off older people very quickly, and some overtreat older people and do not assess for frailty and cause harm. We need to educate doctors, nurses, healthcare professionals, family, and patients that what's important is the middle ground, a good assessment and a good decision on what's best for that specific individual. We're talking a lot about expensive medications as well as gene signature testing that costs thousands of dollars. But may I propose to you that doing a good assessment for an older person is precision medicine. So the last section, some of the special considerations when we treat older patients with breast cancer. So the first consideration is we know that older patients tend to have estrogen-positive breast cancers. And so we need to be good at giving hormone therapy. Now, so these are some of the things that we need to consider in early breast cancer, patients with early breast cancer, such as Frankie. I've talked to you about geriatric assessment and all the different modalities that one needs to consider when deciding on the treatment. Now, your doctor may not have the time to address all of those, but before you go for your appointment, think about some of these things. Are you functioning well at home? Is there concerns about your ability to walk carefully and not fall? Because this information can be really helpful to your doctor. Think about what you want to say to your doctor before you see him or you see her. As I said earlier, life expectancy and the risk of breast cancer recurrence should always be considered. Now, surgery is often the preferred initial treatment because it is a single point of risk that is well controlled. And surgery also offers the ability to help us understand what the risk of the breast cancer is so that we can tailor any other treatment that follows the surgery to that risk. But there are some circumstances where chemotherapy or hormone therapy can be offered before surgery. In some patients with a potentially short life expectancy because of other health problems, starting a hormone therapy without surgery can be appropriate. Now, we talked about, we hear a lot about oncotype DX and some of these gene signature testing that are used to assess if a person should or should not have chemotherapy. Now, these testings can be helpful to assess prognosis in older patients, but they are not validated, a validated tool to tell us if an older person should or should not have chemotherapy. It is one of the considerations, but not the consideration that will make that decision. If chemotherapy is used, a short course is recommended. Your doctor might start you on a small or a lower dose on the first treatment as a test dose to make sure that there is no frailty unveiled. Your doctor should strongly consider giving you something called GCSF, which is something that we routinely offer patients who are at risk of getting low white cell counts and an infection. In older patients, the recommendation is that this should be considered at a lower threshold. Your doctor should consider giving you medications that protect your bone, particularly if you're on hormone therapy with estrogen-positive breast cancers. Now, just broadly speaking, in estrogen-positive breast cancers, hormone therapy alone is usually best. And this is true even in higher risk cancers. There was a recent study called the ASPER 70, which was conducted in France and Belgium, which included 2,000 patients. In this study, they looked at whether patients should have high-risk patients with breast cancer should have hormone therapy with chemotherapy or hormone therapy alone. And in this study, it showed that those patients who did not have chemotherapy did as well as those patients who had chemotherapy. So there may be rare circumstances where your doctor might still recommend chemotherapy after surgery in estrogen receptor positive breast cancers, but that's an exception. Now, whether letrozole or tamoxifen is used depends on the side effect profile. And as Frankie has mentioned, that can be considerable. So there needs to be a good connection with the multidisciplinary team and a good relationship with the doctor to manage some of these side effects if possible. In ER negative or estrogen negative breast cancers, chemo is recommended, but risk of side effects needs to be estimated. And without harping on this for too long, I use a calculator called the BC calculator, which looks at a few measures and is validated to see to assess what is the rate of high or severe side effects if a person is given chemotherapy. Lastly, in HER2 positive breast cancers, the use of Herceptin Herzuma with a short course of concurrent chemotherapy is recommended. What about advanced breast cancer or stage 4 breast cancer? We know that estrogen positive breast cancers, hormone therapy with a CDK4/6 inhibitor like palbociclib is the standard treatment. We know that this treatment works as well in older patients as it does in younger patients, and this was validated in real-world studies, but the side effects can be more severe and dose adjustments are more frequent. In patients with estrogen-negative breast cancer or estrogen-positive breast cancers that have progressed on initial hormone therapy, chemotherapy can be tried, but cautiously, and the recommendation is one chemo agent at a time. And finally, for HER2 positive breast cancers, we do use HER2 targeted therapy in the form of Herceptin, Herzuma, and Perjeta, combined with hormone therapy in ER positive cases or a gentle chemotherapy. In all of this, ask your doctor regularly if there are any clinical trials you can participate in. So I'm going to move on to Dr. Murali's slides, and I'm going to try to do justice to what he wants us to present here. The first thing is, if you decide on breast conserving surgery, you should accept the possibility of radiotherapy. And this is because there is an updated results from a very important trial called the PRIME2 clinical trial, where women over the age of 65 who have had breast conserving surgery were offered no radiotherapy or radiotherapy. And the results were 9.5% risk of another cancer in the breast within 10 years if no radiation is given, versus 0.9% with radiation. So Dr. Murali pointed out that is 9.5% a big deal? And I think what he meant to say that it is a big deal, because your doctor doesn't know if you are in the 9.5% or not. And older women may be at risk of new cancers not being detected. And as Adam had pointed out, free mammograms currently end at 69. And we don't know what the 15-year disease recurrence or overall survival results are from this trial. And so I think Dr. Murali wanted to point out that radiation treatment is generally very tolerable. You will go for a planning appointment for an hour, and then your treatment will be a couple of minutes each time. Usually the treatment is 5 days of radiation, which is the new standard of something that they're offering now, as opposed to the 3 or the 5-week regimen that was previously given. He pointed out that it's important to prevent skin damage using protective cream, and that some patients can feel more tired after treatment, and there's a small risk of fibrosis in the lungs. And radiotherapy is indicated in invasive cancer and also in DCIS. In the final slide, Dr. Murali is harping the same thing that all of us have said here today, that an older woman is not just a number. We need to know the biological and the physiological age and the biology of the cancer, which is how high risk the cancer is, when we make these decisions. Now, in order to have radiotherapy, a person must be able to lie flat for treatment and hold that position. And there are some special considerations. A person who has shoulder mobility issues or has lung function issues, you may have to be cautious about whether radiotherapy should be offered because of the possibility of worsening those conditions. And there are some connective tissue disorders and some genetic conditions that preclude a patient from radiotherapy. So this ends our slide deck here, and thank you for your attention. And we're looking forward to some questions.
Great, thank you very much, Edmund. We are now going to open up for questions. So first question is one for Mr. Adam Stewart. And this lady says, I had a bilateral mastectomy a year ago. The scars have always been uncomfortable despite having physiotherapy, using alhydrin cream and doing exercises. Wearing underwear causes me to feel like I have a wire cut into my body. Doing everyday tasks like housework and so on causes swelling around the scars. I deal with this by taking medication, but would prefer not to. Any thoughts on that situation, which sounds quite painful?
Yeah, it does sound painful. I want to be cautious about advising individual patients about their specific treatments because that's potentially a sensitive topic that's carefully nuanced and probably should be best discussed between yourself and your treating surgeon. But there are some available treatments for neuropathic pain or pain in the nerves in mastectomy scars, and that includes injection of steroids and other such treatments. There are also certain physiotherapy treatments available to women who are suffering from post-mastectomy swelling or edema. But I'd probably be cautious about making further commentary there, Adele, just because it's something that should be taken up with that particular woman's treating surgeon.
And in general, how long might post-surgical pain carry on for, do you think?
Well, after a mastectomy, it's quite common to have post-operative pain for up to 4 to 6 weeks. But after breast-conserving surgery, I hope, Frankie, it'll be all right if I re-quote what you told me a few minutes ago.
Mine was partial.
Yes, so you had a partial mastectomy. So Frankie was telling me that she found it more painful to have a paper cut in her finger than the entire experience of having had breast surgery. Is that correct?
That's really true.
Right.
I said it often.
So what that means is that for many women who are having surgery which retains the breast or conserves the breast, and I say this advisedly, it's in many, if not most cases, actually not a very painful operation, and the recovery is extremely quick. Further to that point, in order to facilitate breast conserving surgery, it's really important to do early detection. And early detection allows women to have smaller operations. No talk would be complete without mentioning the free screening program, Breast Screen Aotearoa, which for women who are New Zealand residents is free for eligible women between the age of 45 to 69, and the number to call to enrol is 0800 270 200. Coming back to Edmund's talk about treatments for advanced breast cancers, I would try to labour that point that early detection can avoid stage 4 cancers. So please do what Frankie did. If you have a symptom that doesn't sit right, please go and see your GP. And the things that older women should be looking for is a breast lump, particularly a hard or craggy lump, nipple retraction, bleeding from the nipple, or skin tethering. Because as I'm sure we'll all agree, that treatments are a lot easier when a cancer is detected earlier than if it's detected later.
Thanks, thank you, Adam. And back on that subject of pain, for those of you who are in North Shore, there is some work being done there looking to address post-surgical pain. So if that's where this person is, you might want to talk to the team there. And it's certainly an area of increasing interest we have noticed recently among patients, with many people surviving breast cancer for longer and being more aware of wanting to get back to a normal life after treatment. Okay, a couple of questions for Edmund now. So Frankie obviously stopped taking endocrine hormone therapy because of the side effects, and we know there are quite a few of those. What becomes the next option after all that?
Yes, yeah. I just want to say that that was a really good attempt on the treatment, Frankie. They've had 2 years on the aromatase inhibitor and 2 years on tamoxifen.
Yeah,
So
I didn't have that long in tamoxifen. I just
Yeah. So the general recommendation for patients who are endeavoring to have adjuvant or hormone therapy after surgery is still 5 years. And this is perhaps one of the biggest challenges because surgery and chemotherapy are treatments that are a sprint, basically. But the hormone therapy component is a marathon. And so it's very important to start the treatment when a person is mentally prepared and ready to start the treatment, and to frame it as to say that this treatment tends to cause side effects which are more severe at the start. But after a while, most patients do live with the side effects or tolerate the side effects. Now, there are, of course, spectrum. There are people who have absolutely no side effects, and there are people who have loads of side effects from the very beginning and are unable to continue. But the majority of patients would be like Frankie, someone who soldiers on with the treatment for a year, for 2 years, sometimes for the whole 5 years. And it's the long sort of stretch of treatment that tends to be difficult. I am often very pragmatic with my patients. I try to address the issues that they have. So so doing a proper assessment at the very beginning to decide on which treatment is the best treatment for the patient is the first thing to do. And once you've started the treatment, I always reassure my patients that if this treatment doesn't work for you, if it's too hard on you, we can take a break of a couple of weeks. And then sometimes when we take a break and we restart the treatment, the person actually tolerates the treatment better. And that those breaks has not translated to a detriment to a person's survival. So you can take breaks if the treatment is causing too much side effects. And if retrialing the treatment results in side effects again, we can try a different treatment. So in your case, a trial of tamoxifen. Oftentimes the challenges are postmenopausal symptoms. And so we're not doing this very well, but there are centers in the world that address all the individual side effects of menopause, better. For instance, myalgia, arthralgia, or aches and pains in the joints can sometimes be helped by exercise and also physiotherapy. For dryness in the vagina, pain during sex, recurrent urinary tract infections, using moisturizers regularly 3 times a week from the very beginning, and using lubricants during sex, and introducing, some occasionally estrogen-containing applicants can sometimes help with the longevity of the treatment. So there are many ways to make the treatment more tolerable. But we are left with these options at present.
Those are lots of really good ideas there. Thank you very much, Edmund. A question perhaps for pretty much all of you. What can I do to get fit or prepared for treatment so that those things don't hit me so hard, those side effects, that chart that you showed, Edmund, I think, with that much greater effect for someone who's a bit frail. Is there anything we can do to prepare for treatment?
Yes, I think doing a proper assessment and also having the multidisciplinary team working alongside the medical team is quite crucial. In many centers of excellence in the world, patients are seen by not only the doctor but a multidisciplinary team at the start to address all the issues that could affect or curtail a person's ability to undergo treatment. Try to optimize the person's health or care before they start treatment. So that would be my point for this.
Right.
My point's very clear. Early detection is everything. As Frankie said, check. Treatments are always simpler when cancer is detected earlier. Surgery is easier, radiation's easier, and chemotherapy is easier. And in many women with ultra small breast cancers, even aggressive grade 3 cancers, what we call T1C or less, won't need chemotherapy for even aggressive breast cancers if it's detected early enough. So I would stress the point, keep checking. And even if you're not eligible for free breast screening, if you're a fit woman, talk to your GP about screening beyond the age of 69 outside of the free program. I would also say at the younger end, particularly with a family history of breast cancer, talk to your GP about screening under the age of 45 as well.
I've got a question for Frankie. Frankie, did you look up any resources when you had the initial diagnosis? What really helped you?
No, I don't think I really had time to think about anything, because I had the surgery in a very, very short period of time. I have an amazing doctor, Sue Laughlin, and she never hesitates when she's what I'd call a good doctor. She knew what it was, but wouldn't say. So there was only, I think, 6 weeks of it being found and then the surgery. So I didn't have time to think about the what ifs or anything. I just did what I was told, because there was lots of, you get this test, get that test. So I didn't have time to really think about it. And then bish, bash, bosh, it was done, so I didn't have much time. And then because I'm working as well, I had to make sure I got myself back to semi-working things, so it happened quite quickly for me. And then of course you've got this break between the surgery and then the radiation, so it gives you time to take a bit of a deep breath and then get on with it. So
can I make the point for those watching at home that radiation, we're talking about radiation just to the breast. We're not talking about radiation to the whole body. And so it's a regional treatment, as surgery is. Chemotherapy, as Edmund has talked about, is a whole body treatment. I'd also like to make a point about the hormone treatment. It's often the case that women have no side effects. And that's my experience from many of my patients that don't, and I'm sorry that you've had side effects from yours. But many women don't have side effects, and those treatments can be life-saving and can reduce breast cancer recurrence long-term.
I agree that it's, it certainly seems that people should give it a try and see if they're going to have the side effects rather than assume. But we do also hear from a lot of women who do have bad side effects, and we know that for many of you at home, that's a problem. We do have another webinar on our website on managing those side effects. It's actually one of our most popular. So by all means, go ahead and have a look at that and see if that might give you some tips too.
And just to add to that, Adele, that oftentimes the side effects subside as soon as the treatment stopped.
Right.
So there's no harm trying the treatment.
Right.
Because there tends to be no long-term side effects.
Yeah.
That's a great point, Ellen. Thank you. What is the new surgical technique that Dr. Stewart showed?
So the new surgical technique that I showed was called Savvy Scout. It's localization of ultra-small tumours using a radar reflector. It's approved in New Zealand, and it's being rolled out in many centres across the country. But it's actually very similar to some other existing techniques in New Zealand, such as mag seed. I believe they're doing a trial of that in Wellington, and hook wires in all parts of the country. And
we just a little bit less technical people. So localization, that's helping the surgeon to find the...
Here's the funny thing, Adele. The smaller the cancer is, the harder it is for the surgeon to remove the cancer.
Right.
And we don't want to remove the wrong piece of breast. And so what happens is once the cancer's been found, and often these are very small cancers, the radiologist will localize that tumor by putting something inside the cancer. So in the video that I showed you, it's called a Savvy Scout reflector, and it helps the surgeon find the breast cancer so that we can just remove a small piece of breast. But I don't want to favour one technique over another, but there are many different localization techniques across the country, including radioactive seeds, Savvy Scout, hook wire, and magnetic seeds.
Great, thank you. We have a few more questions to get through, so we'll power on here. Edmund, a question around radiation therapy, and if you feel you can answer it. For patients with asthma, are there any tips for radiation therapy?
I'll have to pass this question, but I think if the radiation oncologist is here, he would say that that's not a contraindication for radiotherapy. It's mainly patients who have had permanent damage to their lungs, from years and years of smoking, where there's a reduced function of the lung, but radiation may actually worsen that. But yeah, I think he would say that asthma is not a contraindication.
Because patients have to hold their breath sometimes with radiation.
Yes.
Is that a problem with asthma? Or?
Well, if the asthma is well controlled before the radiation, they'd be able to do it.
Yep.
So.
Great. Okay. And another question. with diabetes and thyroid problems, does that mean someone can't have chemo for triple-negative breast cancer?
So no, not at all. Yeah.
Right.
So thyroid problems and diabetes are not contraindications. Again, it's all about us working together to make treatment safe if it's indicated. So no, you can have treatment with most medical conditions.
And that goes for surgery as well. Diabetes and thyroid conditions is not a contraindication to surgery either.
Great. Okay. Okay, let me just see what else we've got here. Let's see. Right. What if I've had breast cancer in my late 70s, does my daughter need to worry about getting breast cancer too? Adam, I'll give you that one.
Well, I think every woman should be breast aware. Having one first-degree relative puts your risk of getting breast cancer, so your daughter's risk, slightly above population risk. But actually, breast cancer is such a common disease these days that it's almost universal that someone has a relative with breast cancer, either an aunt or a grandmother or so on and so forth. If you have had breast cancer in your 70s and you have a daughter who's, let's say, 40, 45, my advice would be to have, firstly, to enroll in breast screen Aotearoa at 45. But if you are the only person in the family with breast cancer, then your daughter should have the regular screening from 45 onwards every 2 years, and to consider having additional screening before that in consultation with a GP. As for your granddaughters, they should just enjoy being teenagers and not worry about breast cancer at all. I have never in my career ever seen a teenager with breast cancer.
Right. Okay.
Nice to know. Nice to know.
Yes. Just a couple of people commented here. Someone's just noted that she was having trouble with her hands stiffening up on the endocrine therapy, but switched to tamoxifen and that worked for her. So that's a good story. And that specialised physio was a great help to her after her surgery. So that's good to know. Some other feedback from people. Let's see, our question for you, Frankie, your initial thoughts when you were told you had breast cancer, what was your sort of emotional?
Well, I was actually kind of astounded because there was a part of me said, it's not cancer, it's some silly little cyst or something that's kind of floating around, because nobody actually told you what a cancer was.
Right.
And growing up, I was always led to believe you don't talk about cancer, it's a dirty word. But when I got it, that's why it took me so long to make the decision. Do I get it checked? Don't get it checked. So all Sunday, I kept thinking about it. And then before I went to bed on Sunday, I was up, I'm ringing the doctor in the morning. And then when I got to her, she was immediately, this is the best thing you could have done, is come because you've come early.
Yes.
Early detection is prime. And she said, because you've done that, we can get on to it. And I don't know who she wrote to or whatever it was, but that was on the Tuesday. On the Friday, everything was getting done. And it was just fortunate. The pathologist, the radiologist, and everybody was at North Shore that Friday. So I was able to get everything done, like wash again, just lying that table will all come to you.
But it used to be a dirty word, cancer, and you're right. And people didn't talk about those things. But actually, the story for breast cancer has changed. Treatments have improved. And it can be a frightening experience to hear the word cancer, but the outcomes for breast cancer have improved exponentially over the last 50 years. So for those women at home considering what to do if you have a symptom, do what Frankie did. Go and get it checked out, and no regrets. You've done extremely well.
Yeah, exactly. Well, I wouldn't be here now if I hadn't, done that. But yeah, check.
A quick question for you, Edmund. For someone who has a history of arthritis and now is also having joint pain on letrozole, familiar story, what do you recommend in terms of pain relief and bone strengthening drugs and so on?
Yes, yeah. So we'll address the bone strengthening side first. So the important thing, again, you've got a webinar on this.
Yes,
topic,
we have.
so
Yeah,
yes.
a recent
Watch
webinar.
that
Thank you.
myself.
Thank you for reminding me.
Yeah, but in essence, making sure there's adequate dietary calcium, making sure that if there's any risk of falling, to mitigate that risk, have monthly vitamin D, and do weight-bearing exercises, and ask your doctor about getting a medication called bisphosphonate to strengthen the bones. Now, as for arthritis and aches and pains in the joints while on letrozole or one of these aromatase inhibitors, the option is to switch to an alternative called tamoxifen. It has a different set of side effects, but that's one option. The second option is you can use simple analgesia to address the aches and pains, such as paracetamol and occasional non-steroidal anti-inflammatory drugs, but long-term use of some of these medications may be harmful. Physiotherapy and exercise is also helpful in this space. So there are ways to mitigate this side effect.
Great, excellent, thank you. Okay, I see that our time is up and I think we've got through pretty much all the questions. Thank you all for joining us tonight, and thanks again to Frankie Robson, Mr. Adam Stewart and Dr. Edmund Ang. And thanks also to our producer, Zara, who's been behind the scenes making everything work.
You guys.
You've all been fantastic. We hope you at home found this helpful. If you have any questions about breast cancer or your breast health, our nurses are available to take your calls, and you can see the number for our 0800 BC nurse line on your screens.